All right. Well, good afternoon, everyone. My name is Casey. I work for the EMS for Children Innovation and Improvement Center. I would like to welcome you to the final Pediatric Readiness Quality Improvement Collaborative session of 2024. We are thrilled to have you all here today. First and foremost, on behalf of the entire PRQC team, I want to extend our heartfelt thanks to each and every one of you for attending and actively participating in this collaborative. Your dedication and commitment have been the driving forces behind our success, and we deeply appreciate the time and effort you have invested in this project. And before we get started with today's session, we would like to acknowledge that the EMS for Children Innovation and Improvement Center is supported by the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. The contents are those of the authors and do not necessarily represent the official views nor an endorsement by HRSA, HHS, or the U.S. government. As a reminder, portions of today's session will be recorded and posted on the EIC website, along with today's presentation. For nurses seeking continuing education credit, please add your first and last name into the chat feature, and we'll share the evaluation link with you at the end of today's session. And for physicians looking to obtain MOC Part 4 credit, please submit your completed attestation form to the collaboratives at emscimprovement.center. And here are the formal objectives for today's session. Right. And we will begin today's session by hearing from Dr. Feuer as we look back on the quality improvement process, and then we will review together data on those who have been participating in PRQC and what you all have been working on. And we look forward to celebrating your accomplishments and reviewing next steps. We'll wrap up and share the session evaluation link again with those nurses seeking continuing education credit. So please feel free to use the chat function or come off mute throughout the meeting for any comments or questions. All right, and with that, I will hand it over.
Thank you. Thanks, Casey, for that summary. And thank you, all of you. I guess I'm just so honored to be involved with this process. And thank you for all that all of your teams have been doing. And this will be a nice recap of talking about how did we get here today to this last session and what were some of the results. So the story began, right, with this team selecting the topics for this PRQC initiative, and then recruiting subject matter experts as faculty for those topics that have been selected, and then developing a framework and sort of the changes that are planned to that we were targeting to reach. And then the next step is to find all of you on the call and find institutions and enroll participants that were coming on this journey. And there was some pre-work for all of you to do, and we had some sessions throughout, right, along with some supports of emails, phone conferences. The teams had monthly team meetings, reports, assessments, some data that you're submitting from your initiative. And then these cycles, that is really the core component of the quality improvement process, which is the PDSAs, the Plan, Do, Act, See cycles that you guys have been conducting along these various initiatives. And really, I think we talked about this in some sessions before in the breakout rooms, but really important to know and remember about PDSAs that, you know, they are small changes, they're small observations. One provider in one shift, one day can run a PDSA cycle and test out something and see how that worked and what can we learn from that. So those have been happening interspersed with these learning sessions, meeting together, sharing the learnings, sharing some of the challenges, some of the barriers, some of the successes and wins. And then now we're getting to this summary and going through together today all the results thus far. Next. And really, this quality improvement collaborative is you know, one of many that I have been fortunate enough to be involved with. And I think it is just really important to highlight quality improvement collaboratives as really important tool for rapid transformation of our systems and our healthcare systems. Because when we're working together in this method, we know that from research to practice, it takes an average of 17 to 23 years, but these QI collaboratives bringing these changes to practice and making them alive and making them workable and sustainable takes a lot less time. So really important tool. And on the next slide, you'll see what we've sort of taken from the observations from QI Collaborative is that QI collaboratives are really efficient and work well when they're founded on evidence-based practice recommendations. So like in this collaborative, we took the topics and sort of what is the evidence around those things and what are the practice recommendations. When they are created in a way which, hopefully you felt that all the sessions that you've joined, that this is a supportive environment. We're coming together to share experiences, to share learnings, to understand each other's and our own challenges and come up together with solutions and learn from one another, as well as from experts and on the team and the various topic experts that have participated throughout this collaborative, as well as your peers. And, myself also, when we participated in these learning collaboratives, learning about how other places are doing this and having that peer support and not feeling alone with some of the challenges and some of the difficulties on the day-to-day, because, change, and I say that as a psychiatrist, change is hard and people don't want change. So managing through these changes and managing through these difficulties, having peers and having this supportive learning environment, really motivational. And then sharing best practices and active strategies that directly impact patients, that are really very practical, applicable learnings that we're sharing through this. And hopefully new networks formed. Hopefully you now know who to go to and who does what, and you learned about each other's institutions a little bit and about where the expertise is around these topics and where can you go. And we really, hope that all of you will carry this work on and continue to become leaders in helping promote continuing these QI collaboratives, because, and we're going to go through the impact, but we know from research, right, when ERs are ready to manage kids and when we're guiding that, the results are just much, much better for all kids. So with that, I'm going to pass it back to Casey to talk a little bit more about the timeline of this collaborative and some of the results.
Thank you so much. So just as sites have been monitoring their progress over the last several months, the PRQC team has also been tracking your progress. And we wanted to take a minute to share with you where we started, where we are today, and what we have to look forward to in the future. You may recall that registration for the collaborative launched in April of 2023 with a total of 212 EDs registered from 42 states and territories. The collaborative kicked off in June of 2023 with a series of fireside chats to introduce you to our 4 areas of focus. Over this time, many of you are busy working to get your POAs signed, which would allow you to begin entering data and utilizing the PRQI platform. When we then began sessions in January of 2024 with 104 sites with a submitted POA. These sites continue to attend collaborative sessions, and many of you over the last 12 months have shared with us updates on your QI projects during those collaborative sessions. And we look forward to continuing to support you all in your efforts through a community of practice in 2025. With this in mind, I now want to share with you a bit about who has been on this journey with us over the last 18 months. At the start of the collaborative, we did have 212 participating sites. The data I'm going to share with you represents only those sites who have registered for PRQI. So the majority of sites participating in PRQC are general EDs who see pediatric and adult patients. And these sites often have a medium to high pediatric patient volume. See some of that information here. These sites are serving in primarily urban settings, but we do have 10 sites that are federally designated critical access or rural emergency hospitals that registered to participate in PRQC. And we are excited to share that 12 of the registered sites have registered for one or more of the previous EIC or Pediatric Pandemic Network collaboratives, such as ED Stop Suicide, the PEC Workforce Development Collaborative, or the first cohort of PRQC. And then we have the Disaster Networking or Disaster Response Collaborative hosted by the Pediatric Pandemic Network. So we applaud you all for your continued commitment to improving your site's pediatric readiness, and we look forward to seeing you all during a future collaborative. A couple additional data points to share with you all. 84 sites indicated that they had previously taken part in the National Pediatric Readiness Project, either in the 2021 assessment or through the current open assessment. If your site has not yet completed the NPRP assessment, you can visit pedsready.org to complete the open assessment for your own records. And then after submitting that assessment, your ED will receive a gap report and summary that will contain your overall pediatric readiness score and the answers to your scored questions. While the NPRQI is the implementation arm of the NPRP, provide EDs with the national platform to measure and reflect and to improve their pediatric emergency care delivery. There are 104 sites who have registered for PRQC and who have submitted a POA and have the ability to utilize that data platform. And then as we look at this slide, you'll see the numbers tell an important part of our journey. We began this collaborative with an impressive 212 sites initially registered, and this number reflects the widespread interest and commitment to our shared goals. And today we have 92 sites who are participating, and we want to again thank those that remained a part of this journey, and despite their various other responsibilities and the barriers to their participation, they continue to engage with us. As shown on that timeline, the 212 sites initially registered to take part in the PRQC, we had 104 who had a POA signed in January of this year. And then we did have some attrition due to staff turnover or competing priorities. We applaud those 92 sites and we appreciate their commitment. As we reflect on the participation of each of these emergency departments, it is important to recognize the true driving force behind their involvement. We know that the success of the collaborative would not have been possible without the dedication of the individuals who make up each of these teams. Every team member has played a crucial role, from our frontline staff to the administrative support and everyone in between. So your hard work and commitment are the backbone to this initiative, and we applaud you. You may recall back in June or July of last year, we sent out a demographic survey to learn more about the individuals who are participating. Of the 662 registered participants, we received 213 responses. And of those responses, we know that 113 participants indicated that they work either as a nurse or a physician in an emergency department. When we then surveyed participants on their experience with quality improvement, we found that the majority of our participants had no formal QI training and had not participated in a QI collaborative before, indicating to the PRQC team that this was something new for many of you. So during that initial survey, we asked each participant if they were the Pediatric Emergency Care Coordinator, sometimes called the Pediatric Champion or PEC. This individual is often responsible for ensuring that EDs follow national recommendations for pediatric emergency care. Some of their responsibilities include familiarizing colleagues with pediatric-specific policies, protocols, promoting pediatric quality improvement efforts, and managing pediatric equipment and supplies. The role of the PEC is important as it's a proven strategy for improving emergency care for children. And having a PEC in the ED is tied to a double-digit increase in pediatric readiness score. So we are very pleased to have 141 PECs register for PRQC, and we are happy to support you in your efforts. On behalf of the PRQC team, we thank you for your hard work, and being an integral part of this collaborative. And I am excited to take the opportunity to congratulate the 7 sites that have successfully established a new PEC role. So if you are on today's call and you are a PEC at your site, you could raise your virtual hand. Okay, people finding the raise your hand button. And we have 1 PEC on our call today. Hazel. All right, Amanda.
Looks like Hazel too.
Thank you.
Nancy,
Malia,
And Deborah.
Oh, we see some in the chat too. Stacy. People struggling to find the raise your hand button. Thank you. Janice.
Stephen,
Nancy. Right. Well, thank you all. And we appreciate you being here, and we identify that your progress and the support, your progress in identifying and supporting the important work of PECs is truly commendable. And the establishment of these roles is a significant step forward in ensuring that our youngest patients receive specialized care that they need. And we applaud each and one of you for your role in that. So thank you all. Then I want to share with you that the EIC strives to support PECs in their work that they do to improve pediatric readiness in their EDs. So to better support our established PECs and those new PECs joining us today, we invite you all to register with the EIC here so that we can share with you updates and reminders regarding the important work that you do as a PEC. So you can scan that QR code here. I'll give you a minute to grab that. I think Melanie will also put that link in the chat for you. Whenever you are using that login or that sign up, please indicate that you are a PEC. Thank you all. And if you are already a registered user on the EIC website, you can go in and adjust your settings to indicate that you are a PEC. Hope that you take advantage of those opportunities so we can stay in touch with you all. Right. So far I have shared with you an overview of the sites and the participants who have registered for PRQC. I now want to shift gears to discuss the quality improvement efforts that we have observed over the course of the collaborative. So over the last 18 months, we have reviewed the role of smart aims and its importance in your QI projects. And we are pleased to share that 74% of those sites who are participating as of December this year have shared with the PRQC team a smart aim. We would like to take a moment to acknowledge those 55 sites who shared their smart aims, as well as other updates regarding their projects over the course of the collaborative. These updates provided valuable insights into the challenges faced, the strategies implemented, and the successes achieved. This exchange helped us all learn from each other and to continuously improve our practices. Your updates have been invaluable in driving our progress, and these updates are often referenced by participants when they're asked which element of the collaborative they find to be most helpful. So we appreciate the dedication and hard work of all of our participating sites and the efforts made by all to address one or more of our 4 areas of focus. Many sites selected to work towards improving abnormal vital sign reassessment and pain assessment. And you can see also the number of sites who indicated their focus on patient safety or suicide assessment. These efforts are made evident in the results of our pre and post environmental scan. Team leads were asked whether or not their site had QI performance measures in place related to one of our 4 areas of focus prior to the collaborative, and again in December of this year. Performance measures on abnormal vital signs and pain assessment are seen here. Again, indicating that improvement or the new identification of performance measures related to those areas of focus. And again, we see the same for suicidality and measurements in kilograms for pediatric patients. We know that change strategies are an essential part of quality improvement because they provide a structured approach to implementing improvement. I'm pleased to share that many of our participating sites have actively implemented change strategies. Specifically, 66 have indicated that they have successfully implemented change strategies as part of their QI projects. We commend these sites for their proactive approach and dedication to continuous improvement. Your efforts are driving advancements in pediatric emergency care. When sites were surveyed regarding their change strategies, they reported change strategies related to staff education, equipment changes or updates to their electronic health record system, or to policies and procedures. So if we take a closer look at staff education, whenever it comes to staff education change strategies, sites reported that they had added posters to triage or treatment areas, as well as in staff break rooms. Pediatric topics are also being included in staff huddles and new staff orientation. We see evidence of this in our pre and post environmental scan results, where 76% of respondents indicated that they had their staff received continuing education on normal pediatric vital signs. And then again, in our 2024 assessment, that's now 94%. That is great to see. And we've also included some examples of staff education that has been shared by some of our participating sites. A number of sites also indicated that changes or updates were made to equipment used for pediatric patients. These included the purchase of new equipment or the relocation of pediatric equipment to triage and treatment areas. When asked in our environmental scan, does your ED use a scale that measures children in kilograms only? 85% reported yes during our baseline survey, and then 86 reported yes in our post-environmental scan data. And when we look at electronic health records, sites reported 30 new additions or updates. These included the inclusion of pain screening questions, stops for reminders for vital sign reassessment, suicide screening questions, or the removal of pounds from their electronic health record system, to name a few. So we know that those are big hurdles, and we want to applaud the work done in those areas, as well as all other areas. Several sites indicated that they implemented new or updated policies and procedures. A total of 26 new policies related to pediatrics have been implemented and related to one of our 4 areas of focus. These changes are observed in our pre and post environmental scan data. So looking at whether there is a process in place for notifying physicians and or advanced practice providers of abnormal vital signs, abnormal initial vital signs during triage, with a pre-performance of 68% and a post-performance of 80%, with an overall 18% increase in performance. And for standard procedures, for a follow-up with a patient or family after discharge of a pediatric patient of high risk for suicide, there was a 96% increase in performance in the pre and post environmental scan data. We know PRQI provides sites with meaningful pediatric quality measures and a data platform to guide improvement in the delivery of pediatric emergency care. There's been 13,424 patient records entered by 80 of the PRQC sites. So these sites have been able to track the quality metrics and performance, support their local quality improvement, and many sites have reported individual improvements in their performance. So here we have the average baseline and post performance for PRQC sites. based on their selected areas of focus. So looking at the percent of pediatric patients with weight documented in kilograms only, again, this is sites who indicated that that was their area of focus. Their average baseline performance was 57.5%, and the post performance of 93.8%. Then we have included here on this slide also the national performance for the percent of pediatric patients with weight documented in kilograms only is 62.9%. So then if we look at the percent of pediatric patients with pain assessed, again, this is for sites who indicated that pain was their selected area of focus. Their initial or average baseline performance was 70.3%, and then their post performance was 81.2%. So exciting to see some gains in both weighing and recording in kilograms, and then in pain assessment as well. Next, we'll look at the percent of high acuity pediatric patients with vital signs reassessed. So sites who indicated that this was their area of focus. Their average baseline performance was 85.8%. And then the post performance was 86.4%. Again, the national performance for that measure is 83%. And then our final area of focus, percent of adolescents who were assessed with a suicide screening tool. For those sites who indicated that was their area of focus, their average baseline performance was 76.9%, and their average post performance was 80.6%, with our national performance being 62.9%. So these improvements are a testament to the hard work and dedication of our participating sites. And we again want to recognize and extend appreciation to their efforts of every team member who contributed to this success. We are excited to share some of that information with you. And next, we're going to hear from Lisa, who provides some additional insights into data on PRQI.
Thank you, Casey. Can we just take a minute and to absorb all of that data? And when you look at the percentage increase, the post-evaluation result information, and benchmark that against the national average, that's just like, wow, just incredible. I think it really speaks to the work of how quality improvement can really make a difference in the work that's being done across all of the sites that have participated in PRQC, and then all of the other sites that are doing any type of quality improvement work. So kudos to everybody. That's amazing. So let's get on to the PRQI data. Yes, next slide. So Casey, Eleni, and myself had the honor of being able to really kind of sit down with some sites and conduct some qualitative interviews, really just to kind of pull out some informative insights about their experience participating with PRQI, which is the data portal. And we collected information about areas of focus and really kind of what influenced that area of focus. The majority of the sites, of course, it was 22 sites total that we got to speak with. 8 of those sites said that they themselves had identified a gap in their care, and that's what drove their area of focus. We had some others that indicated that after entering in their baseline data, they used that information to really inform their area of focus. We had a few that said leadership had a say in what they wanted to be able to focus on, and then there were a few that others that they were not exactly sure, but that's what they were using. In terms of chart entry time, the majority of sites said that it took anywhere between 10 to 5 minutes to actually do the data entry, which is on par for all of the sites that are actually entering in the data. Those that maybe took a little bit longer, there were either a more complex patient chart entry with multiple medications, or there were interruptions in the actual data entry process. And we were really curious about barriers for data entry. So we had folks share with us that, you know, for some folks, they experienced it being a little time intensive in terms of actually collecting the data, especially when it was just one person. The other that indicated a more significant time specifically had to do with, again, the more complex patients, entering in multiple medications for patients, creating the TAP IDs, and then any of the more complex data extractions that had to happen, those often maybe took a little bit more time. And then there were a few that indicated that there was either a lack of support or due to minimal staffing created some challenges with that. But overall, all from the sites that we spoke with, they in total contributed to over 3,500 patient encounters that were entered into NPRQI. Next slide. Also, we were curious about who the sites are sharing their performance data. So if you are familiar with the data portal and you're familiar with especially the dashboards, there's a feature in there where you can actually make a PDF, make an image, make a PowerPoint of the actual dashboard display, which makes it really nifty, especially if you're going to be giving presentations within your leadership, to any regional committees, QI committees, your hospital leadership, to share that data. And so we were curious who sites are sharing their data with. So predominantly with and among ED staff, which is great. Others reported hospital leadership, and then we had some that were saying that it was really important to share the information with their quality improvement team at their site. We did hear from a couple of other folks saying that they were going to conferences and they were actually highlighting the data from their site at these quality improvement conferences that they were attending. Next slide. So exciting news, even though we may be a little sad that the collaborative itself is ending. The good news is that everyone that has been participating in PRQC will still have access to the data portal, to the performance dashboards, and to our office hours, which is really exciting and great news for a lot of folks. When we were doing our interviews, people were really excited to learn that they could continue their quality improvement work through NPRQI. We know that there were some sites that had challenges in getting started with data entry. So even if you haven't done any data entry with this collaborative, you can still start data entry with NPRQI. Next slide. So in terms of data collection targets, specifically for ongoing data entry, we're really talking about, especially when you've looked at your dashboard and you've seen that run chart or the graph view, to really continue to be able to see that view, you want to be entering charts at a regular interval. And so really what we're saying is use your judgment in terms of your ED's team's bandwidth, your patient volume, when determining what that's going to look like. It could be 5 charts a month. It could be 5 charts a week, just depending on the capability that you all have. We have some sites that are doing 30 charts a month. So it's really up to the site to determine what that ongoing data entry looks like. And we understand that things are dynamic within the ED. Staff will leave, staff change. And even if for some reason you have to drop off from data entry for a bit, you are always welcome to come back and you just pick up where you left off. Next slide. So I know that with the collaborative, we've really been focusing specifically on abnormal vital signs, pain, safety, and suicidality. If you haven't had a chance to really kind of look through the dashboard, there are a host of other clinical conditions that sites could consider focusing on in the future. So on the dashboard, there's a filter that says patient clinical group. And when you click on that drop-down menu, you will see all of the other clinicals that are the clinical bundles that are available. So if you would like to maybe do some quality improvement work around head trauma, around seizures, respiratory complaints, vomiting, feel free to experiment with all of that stuff. And again, we'll be here with office hours as well to support that work. Next slide. So in need of technical assistance, you want to make sure that you're emailing Clario, who is the vendor. That is their email up there. And if you have your phone handy, take a quick snapshot of this information that you want to include. So when you are communicating with Clario and you're having an issue with signing in, you want to include your hospital name and the 5-digit number that is associated with your hospital. That's the name that shows up on your dashboard report. If you don't know what that number is, you are welcome to email me and I will provide that to you. You can send them your username, your access level that you have, your user email, and be sure to include the platform name, the project information, and the project code. Those are going to be really critical so that the folks that are helping you will understand how to direct your technical assistance request. And next slide. Also, if you have changes in data portal users, and we typically will see 2 or 3 emails come through each week of needing to add or remove users, you can send that request to Beverly Swanson. She is our admin assistant, and you'll want to make sure that you include the first and last name of the user along with the user's email and the access level that you would like for them to have. Next slide. And again, just a reminder of the data portal link, as well as the performance dashboard link. While there is a dashboard tab in the data portal, that is not where you look at your performance. Your performance is a completely separate link. However, your login credentials that you use to enter data are the same login credentials that you use to access the performance dashboard. And next slide. Closeout data. So internally, we need to be able to close out our data so that we can do our analysis, and we will also be preparing individual reports to send out to folks. So our date for closing the 2024 data set is January 31st, 2025. And I know that some folks are like, wait a minute, I'm just still on my May data. That's okay. You can continue to enter the data. It will show up on your dashboard. But for purposes of our internal reporting, we have the cutoff date of January 31st. So just wanted you all to have that information. And then beginning January 1st, 2025, you can begin entering your 2025 data or wrapping up any of your 2024 data until January 31st. Next slide. So we have our last office hours for 2024 tomorrow from 1 to 3. We have a couple of sessions that are still available. So if you have any last minute questions about your data, if you would like to talk about any quality improvement strategies you would want to work on in the new year, please feel free to sign up. We would love to chat with you about that. And then we will continue to send out office hours registration links in the new year as well. So as folks are continuing along on their quality improvement journey, they can join those office hour sessions as needed. Next slide.
Thank you so much, Lisa. We did get a question through the Q&A feature for you. about the interfacility transfers. That's not a core measure that you filter by. Where would you find that data?
That one is, we don't actually have a report on that one. That one is part of the assessment. Don't have it. I'm going to post the list of the measures in the chat so folks can see that.
There you go. And go ahead and hand it over to Eleni.
All right, well, thank you, Lisa, for sharing all of that information about NPRQI. For our next section, we wanted to share some of the key takeaways from PRQC. So we can go to the next slide. So over the past few weeks, as Lisa mentioned, we gave the PRQC participants and other NPRQI users the opportunity to take part in a qualitative interview with us. This interview gave us a chance to hear in a more in-depth way about sites' overall experience within the collaborative, more details about their quality improvement projects, progress and barriers, and then recommendations for future collaboratives. So we just wanted to say a big thank you to anyone that signed up for an interview and provided us with such helpful insights. So there were some notable themes pulled from the interviews, and we wanted to share a few of those with all of you as the larger group, so you can hear what some of your peers said that they got out of the collaborative experience. So starting with enhanced credibility, it was said that strength in numbers when advocating to leadership was something that was very helpful in making an impact. Next, collaborative sessions provided opportunities for peer learning and networking through site updates and exchanging experiences and resources. So it was noted that that fostered a big sense of community as well as mutual support. And then we spoke a lot about how seeing what goes on in other sites with different volumes or geographic areas broadens perspectives while also remaining a constant of the shared passion for improving pediatric care, no matter where you are in the US or what type of ED site that you work in. We also had discussions around how adaptable resources and tailored interventions were able to support and enhance QI experiences. Next slide. So some of the more specific and identifiable improvements made known to us by 45 sites included achieving their SMART aims, an overall improved awareness of pediatric readiness, improvements to patient care, increased NPRQI performance, the development of more robust and actionable QI plans, new PEC roles being established, and then an overall improved patient, family, and staff satisfaction. Next slide. So a few more takeaways that we wanted to include were that 74% of phase 2 participating sites have submitted a SMART aim to us. 53% of phase 2 participating sites have reported improvements. 84% of phase 2 participating sites have entered data into NPRQI. So as Casey mentioned earlier, we are at a grand total of 13,424 patient records entered by PRQC sites, which is absolutely amazing. And we are so excited about that. Next slide. So now we wanted to take a moment to celebrate your accomplishments and dedication to improving the care of your most vulnerable patients through a short celebration slideshow video. So we also wanted to say thank you in advance to the sites that submitted a celebration slide. So Casey, I'll pass it back to you to play our video. All right, thanks for sharing that video, Casey. As you all could see, it was so exciting to see the variety of clinical areas of focus chosen, the creativity within the QI projects, and the improvements that were made along the way throughout PRQC. So thank you so much again to everyone that submitted a slide for us. And now I will pass it along to Dr. Remick to say a few words.
Thanks, Eleni. You guys are just incredible. It's so exciting to see all these improvement efforts. And I know you know how important this work is, but just to emphasize and echo what Dr. Feuer just put in the chat as well, as you all probably saw in the New York Times, we now know that about 25% of pediatric deaths in the ED are preventable. And you all are the champions of helping to change the lives of families and obviously of those children who present to our EDs. And it's these foundational efforts that are really driving those improvement strategies. The one thing that I will continue to sort of say or spout is you have to be willing to showcase all the great work you do. And I know so many of us do this because it's the right thing to do, or we feel like it's our responsibility, but just remember to talk to your leadership, tell them about the work you're doing, really continuing to advocate for children and use those reports that Lisa talked about that you can pull off of the dashboards to do this. So pediatric readiness is certainly the work of EMSC, but it's also the work of all of you, and we couldn't do this work alone. And we thank you so much for joining this Quality Improvement Collaborative. And I'm going to turn it back to Eleni.
Thank you so much, Dr. Remick. And Casey, I'll let you get on to our last few slides here.
Great, thank you all. So we want to continue to build on this momentum and strive for additional improvements in the future. And one way we hope to support you all in this endeavor is through the PRQC Community of Practice, which will launch in February of next year. We hope that you continue to join us for quarterly meetings as well as office hours to support you in your QI efforts, as well as data interpretation. We look forward to sharing more about this opportunity with you all soon. As we wrap up today's session, I have a number of reminders and next steps to share with you all. So firstly, our participants will be receiving a certificate of appreciation. So please be on the lookout for those in your email and let us know if you do not receive one. We will also be sharing certificates of appreciation with our participating sites next January. If you are a physician who has not yet submitted for MLC Part 4, please do so by the end of this year, and we will begin processing that request. And we encourage you all to submit your 2024 MPRQI data by that deadline of January 31st. If you have not completed the PRQC evaluation survey, please take a moment to do so. Your feedback is very important to us. And then we look forward to seeing you all again next year. I know that was a number of items. If there are any questions, we would be able to address them. But we again want to thank you all for your time and attention to the PRQC over the last 18 months. It's been a pleasure working with you all. And our final item for the day, again, if you are looking to receive nursing continuing education credit, make sure your first and last name is in the chat. And you can scan the QR code or use the link in the chat to complete your session evaluation. So we appreciate your time and we look forward to seeing you all again next year.
Thank you, everyone.
Thank you.